cannabis use. So Parkinson's disease, at least at its core, is a neurodegenerative disorder, and it's characterized by deposits of a protein accumulating called alpha-synuclein within these structures called Lewy bodies in neurons in the area deep within the brain called the substantia nigra. So when we look at the brain tissue under the microscope, we see these deposits of the protein alpha-synuclein that are within the Lewy body, and that is within the neuron, okay? And this Lewy body and the alpha-synuclein deposits cause the neurons to die off. And so what you see on the right-hand side of the screen, and I'm going to use my laser pointer here, this is a slice through an area of the brain called the midbrain in a Parkinson's patient. And you can see that the area of the brain called the substantia nigra, which is supposed to be black, is wiped out on both sides here, okay? And in this person on the right who did not have Parkinson's, but passed from other causes, you can see this area is black. And so these are the cells that die off in the Parkinson's patient and cause many of the motor symptoms, but also non-motor symptoms associated with the disease. And we think of Parkinson's disease, we think of it as an iceberg where there are things that we see, but also things that we don't see. It's a highly complicated condition. The things that we see are the tremor, the stiffness, maybe the balance difficulties, the slowness associated with the condition. But there are many things that people don't see, but patients can experience and suffer from. These include things like constipation, speech problems, anxiety, depression, cognitive problems, so on and so forth. And so one of the things that I would encourage you all to think about when you're asking your doctors about, should I consider a cannabinoid product or should I use something like that for my Parkinson's disease? You really have to be more specific than that, okay? We really can't, there's no drug that's going to help all of the symptoms of Parkinson's. So we really have to be very specific about our goal. Are we trying to address tremor in Parkinson's? Are we trying to address balance in Parkinson's? Are we trying to address sleep? And that's how I would think about it in terms of framing the question for your doctor, whether or not it will help with a specific targeted symptom, because we really don't have a drug that's going to target all aspects of Parkinson's disease or any disease typically, okay? So let's talk now about the matter at hand. We're going to talk about cannabis. And, I get asked this probably 3 to 4 times a day, if not more, during my clinic about whether people should be using this. And it's a complicated question. So cannabis, it's a product that has over 60 active compounds that are isolated from it. The 2 main compounds are THC and CBD. THC is the highest concentration. That's the primary component of cannabis. And then CBD is the second main component of cannabis. THC is a psychoactive substance, tetrahydrocannabinol. And that can cause things like hallucinations, the euphoria, and those kinds of things. And CBD is the part that has the potential therapeutic properties. Nearly all cannabis strains are derived from the sativa or indica strains. And sativa has the higher THC concentrations and produces more euphoria, while CBD has more sedating and analgesic properties, meaning pain relieving properties. So let's talk a little bit more about THC versus CBD. So THC is tetrahydrocannabinol, and that's the major component of the cannabis plant. And this is the thing that really we probably don't want people to get a lot of or get high concentrations of, because it can sometimes cause psychosis, meaning hallucinations, paranoia, delusions. That all is included in psychosis. It can cause cognitive problems, slowing of memory and thinking. It can trigger anxiety. It can impair balance. And these are all things that patients who have Parkinson's are already at risk for. And so THC may bring that on or may make those things worse if they already exist. Cannabidiol, on the other hand, is the next largest plant constituent within the cannabis plant. And that is where the therapeutic potential lies. It may, we don't know, it may have protection, have restorative properties for the brain. We don't know that to be a fact, but it may. It may help with anxiety. It may have antipsychotic effects. And it may be relatively well tolerated. And this is where the potential benefits in Parkinson's may lie, in the CBD part, not necessarily in the THC part, okay? So this is already a very important point that I want people to leave this presentation with. So we know that, medicinal cannabis is becoming increasingly more common and more available. California was the first state to legalize it in 1996. Since then, over 27 or more states have legalized it for medicinal purposes. And in most cases, you need a prescription for a diagnosis of a debilitating condition, but now it's even approved for recreational use in many states. So you may not even need a prescription for it. And, regardless of it being available or not, I think their patients have always experimented with with cannabis, and now with medical cannabis for symptom relief. And, there have been preclinical studies, meaning studies in animals, and also anecdotal evidence where patients will try something on their own and then tell their doctor that, they felt better or whatnot, which have suggested that there may be some neurobiological benefits. But we don't really have definitive studies on the extent of patient benefit versus potential risk at this point. So what is the basis of the cannabis benefit? And now, I'm going to go, because I see patients, but I'm also a scientist. I want you to try to get a sense of that. We want to really think of this from a scientific standpoint, just as we think of any other drug. Okay. So we have cannabinoids within our body. They're called endocannabinoids. And those are found in our peripheral nerves. So like the nerves in your arms and legs, but also in the central nervous system. So in the brain and the spinal cord. And there are potential roles in general for pain, muscle tone, mood, inflammation, and appetite. And those are the kind of roles that we hopefully want to exploit in Parkinson's disease. In the basal ganglia, which is the network of structures that are affected in Parkinson's disease, those structures within the brain have a high concentration of receptors, meaning areas of the neurons that bind to cannabinoids, okay? Regardless of whether people use that or not, our brains have these receptors naturally that the drugs can bind to. Interestingly, in Parkinson's patients at autopsy, the brain tissue actually shows that there's low density of these cannabinoid receptors within the basal ganglia. So we don't exactly know the full relevance of that at this point, but it highlights that, you know, if we were to somehow increase the receptors potentially, that could be a therapeutic option or a benefit to patients. But again, we don't know that for a fact. And there are a variety of cannabinoid-based medications, nabilone, dronabinol, and Sativex, which are approved for clinical use for pain, anorexia, spasticity, which is muscle tightness, and chemotherapy-induced nausea. So these things are approved for other conditions, but not necessarily for Parkinson's, these pharmaceutical grade drugs. And I should tell you, nabilone and dronabinol are THC-based products. So in my mind, those are not really great options for Parkinson's because, like I said, the THC-based products are the ones that cause the negative things that we don't want to trigger in Parkinson's. So I don't see those as really therapeutic options for Parkinson's. Sativex, on the other hand, has both THC and CBD in it. So again, because the THC is in there, I don't think it's a great option for Parkinson's patients because what we want is, if anything, to exploit the CBD, but have low or absent THC. So I hope that's clear. And the effects of this is just a schematic that explains the interactions between the cannabinoid system and dopamine transmission at the basal ganglia level. So as I mentioned, the basal ganglia is the area, the network of structures within the brain affected in Parkinson's disease. And we know that the dopamine system is disrupted in Parkinson's disease. And so you can see from this slide that there's a lot going on between different chemicals within the brain that affect both the dopamine system and the cannabinoid system. And I show this really to just show that there's a complex interplay between Parkinson's disease and cannabinoids. And so there are two types of cannabinoid receptors in the brain that the drugs can bind to. Those are CB1 and CB2. CB1 is found in the central nervous system, so that means the brain and the spinal cord, but especially the basal ganglia, that network of structures affected by Parkinson's. CB2 is really in the immune system, and that modulates inflammation. There may be some CB2 in the basal ganglia as well, but CB1 is really the main one that's in the basal ganglia. So again, I show this to you to kind of highlight that there are specific targets. We have to be very, very specific about what we want to target in the brain if we're going to exploit these cannabinoids as a therapeutic option in Parkinson's disease. So we don't want to just hit the whole system, okay? We want to be very targeted in our approach. And so probably we want to focus on the CB1 receptors, not the CB2 receptors necessarily. Or we want to preferentially target CB1 over CB2. And so now I'm going to go through the level of evidence behind many of the different studies that have been done looking at cannabinoids in Parkinson's disease. And the American Academy of Neurology, which is made up of 36,000 neurologists nationwide who are members, but then also have a core of administrative people who are looking at the science of different things and coming out with recommendations. So to advise neurologists and to guide people regarding patient care, they came up with a way to classify evidence for therapeutic studies, not just for Parkinson's, but for all neurologic studies. And so class 1 evidence is the highest level of evidence. Class 4 evidence is the lowest level of evidence. And so class 1 evidence means that you have a very well-designed, randomized, double-blind, placebo-controlled study where people are getting the active drug or the sugar pill, and the doctor doesn't know what the patient is getting. The patient doesn't know which one of the two they're getting. And the study is done with very high scientific rigor. And so class 1 studies really are what we need typically to have confidence in saying a drug is effective. Okay. Whereas class 4 studies are typically open label studies, where that means we just observed a group of patients. There's no placebo arm. So there's no sugar pill that a group of people got. There's no randomization. And it's just observing that the patient took something and they felt maybe better or worse. And it's maybe some case reports of that, or kind of anecdotal type evidence or surveys. That all falls into this class 4 type of evidence. Okay. So really what we need is, and class 2 and 3 are also randomized control studies, but don't necessarily have all the levels of rigor that a class 1 study has. And so I give you this information because now I'm going to show you the data from the different studies and put them in the context of, is this a class 1 study? Is it a class 2 study? Is it a class 3 study? Or is it a class 4 study? And that gives us, and it gives me, the way I think about it, confidence in how can we really believe the results of the study? How much confidence do we have in what this study is telling us? And I think that's very useful in looking at this type of literature, but this is how we look at literature in general for Parkinson's and drugs in general. So I'm going to go in order, and there's actually only one class 1 study for a cannabinoid or cannabis in Parkinson's disease. And what they looked at is the effect of cannabis on dyskinesia. Dyskinesia is the wiggling movements that patients may have when their Parkinson's medication is at its peak effect, like the levodopa is at its peak effect. You may see Michael J. Fox on TV. When you see him, you might see him wiggling, and that's dyskinesia. And this is a class 1 study, so strong evidence, I would say. And this was a 4-week study, and they looked at only 6 patients, though, with Parkinson's disease who had levodopa-induced dyskinesia. But this was a randomized, placebo-controlled study. And in the first 6 patients, what they did is they've tried to find the dose that works for these individuals. Once they had the dose, then they took 19 patients, and the patients got 2 rounds of medication. A cannabis extract called Canador, or they got the sugar pill, placebo. One group got the Canador first for 4 weeks. They got 2 weeks of nothing. We call that a washout. And then they got 4 weeks of the placebo. And then the other group got the reverse. The other group got the sugar pill first for 4 weeks, 2 weeks of nothing, and then 4 weeks of Canador. And then they looked at this scoring system we use called a UPDRS. It's a rating scale we use to look at whether there was an improvement in dyskinesia, the wiggling movements. They looked at that at the end of the 10 weeks. And like I said, the patients and the clinicians, the doctors, didn't know what the patients were getting. And out of the 19 patients, 17 completed the study. 2 patients dropped out because of side effects. In the 17 patients who finished the study, they tolerated the drug fine, but they didn't have any benefit that made the Parkinson's better, and they didn't have anything that made the Parkinson's worse. So at least for levodopa induced dyskinesia in this small study, there was no objective or subjective improvement in dyskinesia or their Parkinson's. Okay. So this was a high level study, but again, in a small group of patients, but a well-designed study. The next study I'm going to talk to you about is a class 2 study. And in this study, they evaluated 119 patients, and then they had to exclude patients who had psychiatric or dementia issues. And that left them with 23 patients. And then 2 patients decided they didn't want to do the study. So 21 patients signed the consent, and patients were randomized, okay, again, to either the sugar pill, 7 got CBD at 75 milligrams, and 7 patients got 300 milligrams of CBD over 6 weeks. And they looked at motor function and quality of life. And at the end of the study, they didn't find any significant improvement in motor function at the end of the study compared to the beginning of the study. And they didn't find any significant improvement in quality of life at the end of the study compared to the beginning of the study. Now, this is an animal study where we know that looking at dyskinesia, the wiggling movements, there's a chemical in the brain called GABA. And that GABA may be abnormal. The reuptake in the brain may be abnormal, and that may trigger dyskinesia. And when they studied the brains of rats, and they gave them this nabilone, which is a synthetic cannabinoid, they showed that as the rats were given higher and higher concentrations of nabilone, the GABA reuptake decreased. And so that makes us think that if you decrease the GABA reuptake, you might improve dyskinesia. So they had a clear mechanism of how they might improve dyskinesia using this synthetic cannabinoid. And so the same group of people did a class 3 study. So it was a randomized study, but it didn't have all the key things that we want to make it a class 1 study, but they did still have a placebo arm. And they looked at 7 Parkinson's patients with dyskinesia, and they put them into 2 groups. One was given the nabilone, and remember, the nabilone is mainly a THC-derived product, and the other group got placebo. And what they measured is dyskinesia. And interestingly, with the nabilone, the patients did have a significant reduction in levodopa-induced dyskinesia compared to the placebo group. So this study actually, it's a class 3 study, so not the highest level of evidence, but they did show some benefit of nabilone on dyskinesia. The thing that we have to consider when we look at this is it's a small group of patients that they did. It was only 7 patients. Nabilone is mainly a THC-derived product, so they had to exclude patients who already had psychiatric issues or cognitive issues because, again, the THC can worsen or trigger those things. But this may be something that could be promising and needs further evaluation with larger studies. So the nabilone is something, again, that needs further research, but this is one thing that did show an improvement in dyskinesia. So you remember now, I showed you CB1 and CB2 receptors, and I told you that CB1 is the main one that's in the brain. So I didn't mean to get too technical with everybody, but there was a reason behind that. And it's because they developed a CB1 antagonist, something that blocks that receptor. And This study was class 3 evidence. And what this group did is they looked at 24 patients, and they gave them actually one of 4 different treatments, all of which they thought were potentially promising to help with Parkinson's. The CB1 is the antagonist, is the only kind of cannabinoid-based product. The neurokinin B that you see there and the neurotensin have nothing to do with cannabinoids, but they're just other drugs that they wanted to look at. And then they looked at the sugar pill. And so the 24 patients were randomized into one of these 4 treatment groups, and they looked at motor function and dyskinesia in these patients who are on this for 1 month. And they didn't find any benefit with any of these 4 drugs, or comparing any of these 4 drugs in these patients. So again, this CB1 antagonist did not show benefit for Parkinson's in motor function or dyskinesia. So now we're going to move to some class 4 studies. And this was a study that was done in Israel. And this is a telephone questionnaire where they basically called patients on the telephone in Israel. They called 47 Parkinson's patients who had experimented with various forms of cannabis for at least 3 months. And you can see that a huge number, 82%, said that they had improvement with their symptoms. 72% said stiffness improved. 73% said tremor improved. 81% had an improvement in pain. 71% had an improvement in sleep. But almost 60% had at least some adverse effects. Okay. The most common adverse effects reported were confusion, anxiety, or hallucinations. That occurred in about 17% of patients. 6.5% reported short-term amnesia, but none of the patients reported hospitalizations or severe adverse effects due to cannabis use. And so you can see, something like this is exciting, but also problematic at the same time. Like, we don't know what all of these people took, how much they took. Did they have it? Did they smoke it? Did they ingest it? Did they have it in a brownie? Where did they get it from? What was the concentration? So, these kinds of studies show us that, there may be therapeutic potential to these types of medications, but we really need to hone in and be very, very specific on what patients are actually getting and what is it specifically that it's actually improving, and can we do that reliably over and over? Can we reproduce those effects again and again? Or is it something that is a transient effect that, is not reliable? Here's another class 4 study. So again, lowest level of evidence, patient experience in the Czech Republic. So they sent a mail by mail survey, a snail mail survey to patients, 39 patients. And you can see in this group, 45% or almost 46% had mild or substantial alleviation of general symptoms. Just over 30% had an improvement in their tremor. 44% had improvement in their slowness. That's what we call bradykinesia. 37% had improvement in their stiffness. 14% had improvement in their dyskinesia, the wiggling movements. And only 5% reported worsening of their condition. So again, not high level evidence, not very specific evidence, but kind of some nudging that there's something maybe here that needs to be further explored. So this is a study looking at actually whether CBD helps psychosis in patients. So this was a study that was what we call an open label pilot study. So that means the doctors and the patients knew that they were going to get CBD. There's no placebo arm. There's no sugar pill. So 6 Parkinson's patients who had psychosis, for at least 3 months. So they already had hallucinations or paranoia or delusions. They were given the ability to dose themselves, or they were given flexible dosing ability for CBD. And the doctors then gave them these rating scales, so specific kind of questionnaires. And they showed that there was some, sorry, please mute yourself there. I'm getting some feedback. And they showed that there were no adverse effects, but there was some decrease in the motor function, so improvement in the motor function, but also some improvement in these psychiatric and psychosis questionnaires with the CBD treatment, okay? So again, so patients who had psychosis actually improved with CBD over 4 weeks. Again, we don't know, there was no placebo arm or sugar pill arm. So it's hard for us to directly infer that, you know, it's from the CBD and that the patients didn't just spontaneously get better on their own. It's only 6 patients. But again, it shows us that there may be some therapeutic potential here, but this has to be explored further. So RBD is REM sleep behavior disorder. This is where patients yell out or act out their dreams at nighttime. They may punch their spouses, unfortunately, they may fly out of bed. And so this small study was done in 4 patients only with RBD, and they got 6 weeks of CBD at different doses. Over the 6 weeks, all 4 patients had a reduction in their RBD related events. And then interestingly, once they stopped taking the CBD, the RBD came back, the acting out of the dreams returned. So I think, you know, that's provocative, but it's only 4 patients. You know, that's not a large number of people. There's no placebo arm. But again, it points to the therapeutic potential of these CBD products for these things. Here's a study that was done in 1990, so an old study, 30 years old. And this was to look at tremor in Parkinson's disease. Again, this was a class 4 study, so not strong evidence. There's no placebo arm, no sugar pill arm. 5 patients who had severe Parkinson's tremor were looked at. On day 1, they got a 1-gram marijuana cigarette. And the doctors assessed their tremor using a special scale called the Webster scale. On day 2, they got 5 milligrams of diazepam, which is Valium. On day 3, they got a relatively high dose of levodopa, which is the gold standard medication used for Parkinson's disease. On day 4, they got another drug called apomorphine, which is an injectable drug that we use to treat Parkinson's sometimes. And on the scale, the tremor scale, none of the patients had benefit or relief after using the marijuana cigarette, but all 5 had some benefit, at least with the levodopa and with the apomorphine. So again, not a very scientifically rigorous study, but it shows that, you know, we don't know what was in this marijuana cigarette necessarily. What is the concentration? What is the strain that the patient got? Did all patients get the same strain within their marijuana cigarette? You know, so these are all things that have to be taken into account, and why, you know, the results can be so mixed when people may talk to their friends or family about the benefits or side effects of using this. So here's a class 4 study, again, not a high level of evidence, but this was for motor fluctuations. This is when, you know, patients who take levodopa, over time, the medication may not work reliably. So the medication may work and then may not work. The levodopa may work, may not work. And so they have this kind of up and down throughout their day where the medication, the levodopa, can be unpredictable. We call that motor fluctuations. And so they looked at 22 patients who had been using medical cannabis for at least 2 months, and they evaluated them before and 30 minutes after inhaling half a gram of marijuana. And interestingly, there was some improvement in their motor functionality. There was some improvement in the tremor, stiffness, and slowness after the marijuana consumption. There was some improvement in pain intensity, and there was some improvement in sleep quality in 12 patients, actually greatly improved in 12 of the 22. And then in 8 patients, only mildly improved. So again, this is not a high level study, not very rigorous science here, but again, points to some of the therapeutic potential of cannabis for motor fluctuations. But more rigorous studies are needed, and we need more patients in these types of studies to understand if it's really going to help or not. So now I'm going to go to the most recent study that was conducted by one of my good colleagues, Maureen Leahy, and she's in Colorado, at the University of Colorado. And this was just published last year, September of 2020. And they studied the effects of cannabis in Parkinson's disease by focusing on safety of a range of doses of a very purified CBD formulation called Epidiolex. So I want to talk to you guys about what Epidiolex is very quickly. Epidiolex is the only FDA-approved cannabidiol, so it's pharmaceutical grade cannabis product, and it is actually FDA approved for seizures in children for 3 really devastating neurologic conditions called Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis complex. These are terrible, terrible conditions that affect the pediatric community. And with rigorous science and using this very purified pharmaceutical grade form of Epidiolex, they found that it is effective for seizures. So doctors do prescribe this for seizures. And the dose that you need to influence the brain to control seizures is about 25 milligrams per kilogram per day. So it's weight-based. So depending on the weight of the child, they tailor the dose based on the weight for the patient. And so my colleague, Dr. Leahy at Colorado, wanted to figure out, was this safe in Parkinson's patients? What is the range that patients could tolerate before they develop side effects? And so she tested the range of 5 milligrams per kilogram per day, all the way up to 25 milligrams per kilogram per day. And that number 25 comes from the seizure literature. So that's why they chose that range. And now I'm going to show you kind of some of the challenges in doing this kind of research. So at the time that this study was done, the US governmental policies required that if you wanted to do a study of cannabis research, a high-level study, you had to get it from NIDA, which is the National Institute on Drug Abuse, or another Drug Enforcement Administration registered source. So you can't just get it from anywhere. It has to be from NIDA itself or an approved DEA registered source, okay? Because at the federal level, there are still many, many regulations on cannabis products. So even though people are decriminalizing this and whatnot on the state level, there are still regulations at the federal level which limit what we can do. So interestingly, NIDA did not have a cannabis product with a desired dose of CBD that also had low THC, because remember, the THC is what may cause the adverse effects. So they really wanted a product that had high CBD and very low THC. And so they had to get this from this DEA registered approved source, and they were able to get it. So they recruited Parkinson's patients, and the patients could not be in the study if they had drug or alcohol dependence, if they used dopamine antagonists within the last 180 days, which are specific classes of medicines that can affect mood and things of that sort in Parkinson's disease. Sorry, that should be dopamine agonists within the past 180 days. And then also currently taking specified medications that can increase liver problems or liver enzyme issues. This was an open label study, so there was no sugar pill or placebo arm. So that's why it's a class 4 study. And the goal was to look at safety and tolerability. Was this safe, and did the patients tolerate it during the duration of the study? And the dose was increased from 5 all the way up to 20 to 25 milligrams per kilogram per day. And that was maintained for 10 to 15 days. So here is the characteristics of the patients at the start of the study. So they had 13 patients who started in who they had safety data on, and 10 patients who they looked at whether it was effective. Based on these scores, these UPDRS scores, this tells us that they kind of had moderate Parkinson's disease, mild to moderate Parkinson's disease. This Hoehn-Yahr stage basically tells us their balance was pretty good. MoCA is a cognitive screen, and it's out of 30 points. So on average, they had 28 out of 30 points. So from a cognitive standpoint, they were pretty good. And the average patient was on almost 400 milligrams of levodopa per day. So not high doses of levodopa. That's about 4 yellow tablets of your carbidopa levodopa per day. So not taking a lot of medicine necessarily. And so what were the adverse effects reported in the safety group? So all patients reported at least some adverse effects. So 100% of them had at least one adverse effect. Diarrhea was the most common one. 11 out of 13 patients had diarrhea, so 85%. 9 out of 13 had somnolence. So they had, they were sleepy, basically, 70%. 8 out of 13 had fatigue. 4 had weight gain. 3 had abdominal pain. 3 had dizziness. And then you can read the rest over here. And so this is just showing us graphically by dose that when you look at the percent of patients that had any side effect out of the 13 at 5 milligrams, 70% of them had at least one side effect. By the time we got to 25 milligrams, they all had a side effect of some type, with diarrhea, fatigue being the most common ones. At 20 milligrams, so as they went up, you can see that only 10 patients of the 13 were able to get up to 20 milligrams, and only 3 were able to get up to the full dose of 25 milligrams. So at 20 milligrams, you can see that you still have this roughly 70% number having at least one side effect. But again, diarrhea is here. But once you got up to 25 milligrams, everybody had diarrhea. They looked at tremor, whether tremor improved. No change in tremor in any patients from the start of the study to the end of the study. There's no placebo arm. So that's what it means when we say it's open label, and it was not blinded in any way. And so we can't really draw conclusions about efficacy. And also it was just done in a very small group of people. So again, we can't draw conclusions about efficacy. So the other thing that I should tell you is that the study found that relatively high dose of CBD, so they were getting about 1,600 milligrams per day with less than 0.15% of THC, had mild adverse effects. Somnolence, the sleepiness, fatigue, diarrhea, and maybe some effects on the liver and gallbladder system. Because when they looked at the liver and gallbladder enzymes, those became abnormal with this product. The sleepiness came early in the when they started the dosing, but improved as time went on. The diarrhea basically got worse as they went to higher and higher doses. In general, the adverse effects are similar to what is reported in the pediatric epilepsy population. So now I'm going to tell you that there's two other studies that are in progress. One is from the same group that I just showed you from Colorado, my colleague, Dr. Leahy, and they're going forward with an efficacy study to see whether it helps the benefits of Parkinson's disease, particularly for tremor. The projected completion date of this study is June 2021. I don't know if they are on track to finish because of COVID, but that is what the completion date is listed as from the information I could find. And it is going to be a high-level study. It's a double-blind, randomized control study, and it's 60 patients. So that's pretty good. So I'll be excited to see that study, and that will potentially be the first high-level study in years that gives us, some real answers and really using high-grade cannabinoid product. And then my colleague, Susan Fox, who's a very well-established researcher who's in Toronto, is using a cannabis oil for pain in Parkinson's. They're looking at 3 different doses, and this is an approved drug in Canada called Canimed. And it's approved by the equivalent of the FDA for other things in Canada. So the FDA equivalent organization in Canada has approved this Canimed for other things. And the 3 doses they're examining have differing levels of CBD and THC. So it will be interesting to see how the patients do with this. It's only 15 patients. It's going to be randomized, open label. So they're going to get randomized to the 3 different doses, but there's no placebo arm, and the patients won't know what dose they're getting. The study was supposed to be completed in July 2020, but probably because of COVID, that got derailed. And so I have not seen any results yet, and no data is reported thus far, but I'd be excited to see what those results are, and we'll go from there. So in the interest of time, so that I have time to answer questions, I just want to say that, when you're getting CBD from dispensary products, the things that you have to remember is that the products that you're getting from dispensaries it is very variable what you're getting. On average, the dosing is anywhere from 2 to 200 milligrams per day. And that is much lower than the study that I showed you by Dr. Leahy from Colorado, where they were using about 1,600 milligrams per day. And that reason that's important is because from the epilepsy literature, we know that we may need to be in that range to have a meaningful effect on the brain. So that low dose may not be enough to give us a meaningful effect on the brain, but we don't know. The other thing is, other than dosage, how you take it may affect the outcomes. So smoking it versus vaping it versus eating it, might result in more immediate benefits versus, and may have shorter lasting effects versus taking it in a capsule form. So all of these things really influence how the drug works and how well it works for somebody. And so lastly, you know, our the American Academy of Neurology, which, like I said, has 36,000 practicing neurologists and neuroscientists. It's a professional organization that makes recommendations for neurologists and scientists like myself. And basically, they say that right now, the medical evidence is limited and does not support the use of cannabis products for Parkinson's disease. There's inconsistency in inaccurate labeling because most of what you're getting is not, or everything that is out there is not under the purview of the FDA. So we don't actually know definitively what you're getting when you're getting it from a dispensary. We need higher level research, higher level studies. The American Academy of Neurology does say that it works for epilepsy, the things that I mentioned for those 3 devastating pediatric epileptic conditions. But we need more high level evidence to determine its effectiveness for Parkinson's disease. And we cannot extrapolate the results of high quality studies. So a study that was done that looks at pharmaceutical grade cannabinoid product, we cannot say that something that you get from a dispensary where we don't know the concentration of what's in it is going to give you the same results as a pharmaceutical grade product where we know exactly what's in it. And so at this point, I think, you know, we can't recommend, I personally, as a scientist and doctor, don't have enough evidence to recommend it to patients, but I think it has a lot of potential and studies are being done. And we will have more rigorous scientific data, but we also need help from the government because these federal regulations make it difficult for doctors to do the studies and get patients the data that they want to determine if this is going to work or not. So, so it's not just that the studies have to be done, but we need the government's help to get this done in a efficient and time-effective manner. Okay, that's all I have. And
can I say a few things?
stop there. Sure. Okay. So, I'm going to actually open it up to Sheila. She's going to moderate the questions for us, and then we'll go from there. I'm going to turn it back to Sheila.
Thank you, Dr. Paul. That was great. If you do have a question, I suggest putting it in the chat box, and I'm going to go through each question at a time. If you do not know how to do that, bear with me. Let me get to the questions that have been already asked, and then we will go from there. So one of the first questions is, how do you target CB1 versus CB2 receptors?
Right. So this is what the pharmaceutical companies essentially need to do. They develop these molecules and then they test them in animals to determine whether they can preferentially target that specific receptor or not. So this is where we need the help of the pharmaceutical industry to do that. And it may not necessarily be that we need to only target CB1. Like I said, CB2 plays a role in inflammation. And there is, there is some evidence that inflammation plays a role in Parkinson's. So, but we want to probably preferentially hit CB1 more than CB2 with these kinds of drugs.
Okay, the next question is, what explains the fact that there are so few class 1 studies of cannabis effects on dyskinesias? Lack of funding or lack of volunteers, or is there another reason?
Yeah, so I tried to highlight some of that with kind of showing you the governmental regulations in getting really pure pharmaceutical grade drug to study for different conditions. And I think that is a big challenge, actually. One of my colleagues got funding to do a study of cannabis for Tourette's syndrome and for tics and Tourette's. And unfortunately, the doctor was not able to get past all the red tape and regulations to actually get the product from the pharmaceutical company. And so they couldn't do the study. They had to give the grant money back. And, it's unfortunate that, they worked hard to get the study approved. They got the funding, but, these pharmaceutical companies also have their own interests in what they want to pursue and what they don't want to pursue, and kind of what's in it for them. But also there are governmental regulations. And so this atmosphere makes it very, very difficult for us to do the studies. And so we need more groups working together, the pharmaceutical industry, the research community, and the government to help do these studies. I don't think there's any lack of volunteers.
Okay, one more question. What about the use for pain that seems to be related to PD? Are there Class A studies related to pain?
Right. So as I mentioned, there is no Class A study related to pain. I did mention that Dr. Fox in Toronto is doing a study looking at pain, but it is going to be a Class 4 study still. But nonetheless, it's a first step to start to look at pain. There was one study that I did show earlier, and I'm just going back. There was a study that was done in 2014 where patients did show some improvement in pain, but again, that was a Class 4 study. There's no placebo arm. So, so again, not high level evidence, but some evidence.
Okay, Mr. Steinman wants to just add something. Mr. Steinman, you can add it now. Go ahead.
Well, can you hear me, doctor?
Yes, I can.
Yeah, my wife's been using cannabis for many years. I'm a big believer in it. She initially started using it for sleeping, very effective. We're in Florida, so we had to get our stuff from California, and she was using a hybrid then, indica and sativa. And she uses it for anxiety, primarily THC. She uses it for sleeping, primarily indica. And there was a big study done in Germany. I noticed you didn't mention that German study that apparently is now hitting the American medical journals, and seemed to show that THC is quite effective. CBDs, maybe based on what you just said, she's never been able to get enough or large enough. I've never found a CBD to help with any of those issues. I know with her anxiety and when she starts getting that dyskinesia going, especially after she's taken some Cinemet, which seems to bring it on, she can get calmed down, and tremors will fade and the dyskinesia will fade. And that's pure THC. The problem, as far as I can see, is nobody is really taking it all that seriously. They could do huge studies of this. And also, I guess, the complexities of cannabis. Each flower is differently. So if what you said before is exactly right. How you're doing it is one thing, but two flowers off the same plant can differ. So have they reduced it then to a pure oil where they all have the same characteristics? That's another problem. So I'm just throwing that out there to discuss. Yeah. It seems like, it doesn't seem like, and you go to doctors, her movement doctor, we mention it, doctors don't know anything about marijuana.
Yeah.
They don't know about cannabis.
Yeah. Yeah. And I think I appreciate your comments, and I can tell you I have several, if not many patients who use it, just as you mentioned that your wife does, and who have mentioned that there are some benefits for sleep and pain and whatnot. And these are, you know, that's great that it's helping in your individual case, but you know, to recommend it is another thing, because
Yes.
you know, if somebody has a problem with it or they have a drug interaction, you know, we know the challenges of the medical system, the legal system, and all of these things that exist, and we want to give our patients really evidence-based data. And I am familiar with the German study that you mentioned as well. But many of those things that are being done in Europe are not available in the States. That's part of it as well. And so I had to pick and choose which studies I'm going to show, which I showed. But we do need more cooperation, like I said, from the government, from the pharmaceutical industry, and the doctors, I think, are willing to do the research. You know, there are plenty of people who want to do it, and there are patients who want to do it. So I think it's a huge unmet need. It needs to be done, because, you know, of course, I as a doctor, I never want to hold something back from a patient that might help them, but I also don't want to cause new problems for an already very complicated condition.
Yeah.
So I agree, we need to get moving on this, but there are, as I mentioned, many barriers to that. And in terms of, you know, what you're saying, that doctors don't always know about it, it's true, because there are so many strains, there are so many different types, and
Absolutely.
we
Biggest
just
problem.
don't know what is what. You know, I have somebody who will bring in, you know, oh, I got this strain from California.
Right.
What do you think about it? And I'm speechless. I have no idea what to say.
Right. Yeah, we got 10 different things up there because there's also an inconsistency. One time it worked, and the next time it's not working. So,
Exactly.
you know, yes, you're 100% correct.
Exactly.
You know,
And so what we really need is something that is going to be consistent if we're going to use it. And I do also appreciate what you said, that, you know, when you started using it, you were using it for a targeted symptom, sleep, okay, or pain or dyskinesia. And I think that's how we have to think about this when we're talking about it with our doctors and when we are designing studies. Like I said, if we say for Parkinson's in general, that's going to be the wrong approach. There's no drug that's going to help Parkinson's in general or every symptom of Parkinson's. So we have to be very precise in our questions and what we're looking to get out of the drug.
Yeah, well, that's how it started. Because one day she came out of the bedroom and she was getting the dyskinesia was coming, which I sort of call it the anxiety feeling. And I said, geez, you smoke it for sleeping, and just a puff or two is all we're talking about here. I said, why don't you go take a puff now at noon or 1 o'clock for this anxiety and the dyskinesia you're feeling? And she went, and absolutely, it calmed her down. She laid down for a half hour, and everything just leveled out. It was, you know, so I believe in that as a up and coming huge drug for so many things. So
sure. Yeah, and the last thing I'll just make a comment about that is the pharmaceutical industry is definitely keeping their cards close to them, because, you know, there's a lot of money to be made off of this, and they are really tightly controlling how they're making it available for studies as well. And so I think you have to keep that in mind. So I appreciate your comment. Let's move on to the next question. Thank you, sir.
Okay, next question is, before starting the use of CBD, should I have a discussion with my neurologist? My son was visiting this weekend and got me to try it Saturday evening. I was able to have a deeper sleep experience.
Yeah, I always encourage people to be just very open and direct with their neurologist. I mean, I think nobody's here to judge or, kind of wag fingers or anything. You know, this is just, you want to be better. And I think the more information the doctor has, the better it is. And we're here to help and advise you. So I think it's always good, because if there is an issue, God forbid, then the doctor knows what it's from. And if there's an interaction that they're concerned about, they can guide you appropriately. So I always think it's good to put the doctor in the loop. And, and if for some reason you don't want it in the medical chart or something, some people will say that to me. I will say, okay, I won't put it in the chart. That's fine. But at least I know, and just remind me that that's what you're doing. So as we're making decisions about care in general, I know about it.
Okay, next question. How reliable are the success stories on the internet regarding PD and CBD oil related to tremors?
Say that one more time.
Sure. How reliable are the success stories on the internet regarding PD and CBD oil?
Yeah, I mean, again, like I said, this is anecdotal evidence. We don't know that individual patient's situation or scenario. So I think, to me, that kind of evidence is not very reliable. And even in my own patients who have used it consistently, and from Mr. Steinman, who also made this comment, he said, that there's some days it works and some days, there is some variability to its efficacy in people who do find it effective for one thing or another. So I think there's too many variables. I don't trust a lot of what I see on the internet personally. And I like to, get it from reliable sources, and we don't have good data, and that's sorely missed. And we do need that.
Okay, your patients that do use the CBD oil, what doses do they find helpful? I have some that is 615.8 milligrams, and I am looking for more direction.
Yeah. So again, I want to be clear and say that I am, as a scientist and doctor, I'm not endorsing that you should use this. But for people who are using it anyway, because obviously people are going to do what they want to do, is to, if you're using the CBD oil, to be very conservative, use 1 or 2 drops of a low dose. Very often the people that produce these oils, they make it in 300, 600, 900 milligrams. I would start with the 300 milligram, the lowest dose, dilute 1 or 2 drops of it in a couple drops of water, and then take it that way if you're going to take it. But like I said, I'm by no means, from a scientific standpoint, endorsing that you should do that. But like I said, I'm happy to provide some information about what people have done and found to be works for them.
Okay. About 4 or 5 years ago, a lot of noise was made over using low dose naltrexone for Parkinson's. Whatever happened to it?
I'll have to be honest with you. I have to go back to the literature. I haven't looked that up in a while. So I don't have a definitive answer for you now. I do apologize. But naltrexone is, obviously, it's not in the CBD family of drugs. But I haven't seen any major articles on that at this point. If you're looking for evidence for different things, I'm going to type in the chat. You can go to clinicaltrials.gov. And if you're interested in looking at, what is going on in the world, any study that's going to be done, that is going to be published one day, or that they're going to make recommendations based on, has to be registered on clinicaltrials.gov. And so you can type in naltrexone and then Parkinson's and see what is being done worldwide, and follow the literature that way. So unfortunately, we have to stop here. That's all the time I have for today. So Sheila, if you can field the questions, and I'd be happy to take more questions offline, after the talk.
So if anybody has additional questions, or we didn't get to your question, please send me your question via email, and then I'll be able to relay it to Dr. Paul and get you your answer. So that is it for this afternoon. I thank everyone for coming, and we thank Dr. Paul for that wonderful presentation. And if everyone is joining us tomorrow, I will see you all again tomorrow.
Thank you all
Thank
again
you.
for taking the time to join. Have a great rest of the day.
Thank you,
Thank you.
everyone.
Bye-bye.